focus on C-spine, then I'll put a video online for T-spine and L-spine. And what we're going to look at is positioning. We'll talk about positioning. We'll look at good images. We'll take a look at some mispositioning images and look at some common fractures as well. I understand that most of your spinal work is going straight to CT now, and that's fine. You may find yourself in a place that doesn't staff CT 24/7, so you may still have to do some spinal work still, depending on where you're working. So collimation, I think I've touched on it before that your collimation is, important to prevent overexposing the patient, but some of your hospital protocols are going to call for a lack of collimation. Some of your protocols, especially in trauma situations, are going to call for a lack of collimation. Some of your doctors prefer you not to collimate on some of these views, and we'll talk about it when we get to it. But collimation doesn't have the effect on the image that it used to have quite as much. You still have the scatter radiation laying down a layer of density, but in as much as messing up your contrast, it's not as significant as what it used to be. So it's all about patient dose, limiting patient dose. So, but follow the hospital protocol, and the examples of when you might not collimate are on an L spine. Sometimes your doctors, your radiologists prefer you not to collimate on AP of the L spine because you may have referred pain from gallstones or kidney stones that are causing back issues. And granted, those are generally flank pain, but sometimes your patients are pretty inspecific about where their pain is. They just say, I have back pain. Okay, so where is your back pain? It's in my back. You get into this, circular conversation with your patients. It just doesn't go anywhere. So some of your doctors prefer you shoot a KUB for your L spine, but also whenever we're doing traumas, the KUB becomes the AP of the L spine. So I'd say probably within the last 20 years, I've not seen an institution that would shoot an AP L spine and a KUB. The KUB becomes AP of the L spine. And the same thing with T-spine. The chest x-ray becomes the AP of the T-spine. So in those cases, your AP of the T-spine is without collimation. So the things that you'd be looking for there would be things like a pneumothorax, and what might potentially be causing the pneumothorax, like broken ribs, tumors, anything like that. So collimation is all, it's good, but just make sure you follow the hospital protocol and the doctor's protocol. So we're going to talk about a lot of different types of fractures, specific fractures, especially in C-spine. T-spine and L-spine, it's really going to come down to compression fractures, subluxation, but we're going to look at specific anatomical fractures in C-spine and what to look for in those, and which ones are relatively stable and which ones are highly unstable. So subluxation, remember, is just a sliding of one vertebra on top of the other. We're going to take a look at where it is that you're going to see which projections we're going to see those different fractures the best in. So where we're going to see most of those are going to be on the lateral, and we'll take a look at some images of those. But on the lateral, you should be able to visualize the fractures, subluxations, which are dislocations with presence of actual fractures or not. You should be able to visualize your fat pads, your disc spaces, the height of the vertebra and the height of the disc space, and to a lesser degree scoliosis. Now remember, whenever you have a scoliotic patient, your lateral is always going to be rotated. You just can't get away from it, right? It goes all the way back to your first semester, when we talk about chest x-rays. Your lateral is always going to be rotated. You just can't get around it. That holds true for T-spines or L-spines, either one. So always evaluate your AP before you shoot a lateral repeat for rotation. Make sure the patient doesn't have scoliosis. We're going to talk about a couple of different types of scoliosis as well, and what the end result of scoliosis may be. So when we're comparing the projections on the obliques, remember what we're going to be looking at is, depending on the anatomy we're looking at specifically, we might see the zygapophyseal joints, right? But we might see the intervertebral foramina. So on specific anatomy, we'll see the zygapophyseal joints on the obliques, and on the lateral, we'll see those zygapophyseal joints. And then intervertebral foramina on certain projections on the obliques, and those are going to also be on the laterals on some anatomy. So the things that we're going to be able to visualize sometimes on the obliques are specific pathology, or it's really trauma, called unilateral lock facet, which is going to be more difficult to evaluate on laterals, especially the lower end of the lateral, down 6-7. So you should see disc spaces, but not as significantly as what you will on lateral. And then on APs, you can kind of see fractures, you can kind of see disc spaces, and you can definitely make out scoliosis. So again, trauma, in a trauma situation, the patient's going to be in a C collar. You never remove the C collar. If you have an ER doc say, yeah, go ahead and take the collar off, really what you should say is, no, you'll be doing that, right? Go ahead and get the patient off the backboard. Yeah, you're going to want to come with me for that. I know that probably you've seen some of the technologists do that, but if that goes badly, if the doctor didn't really do a good job of clinical evaluation of possible fractures, and something goes bad and you've taken the patient off the backboard, or you've taken the patient out of the collar, it's going to fall on you. I was practicing under the doctor's license. It's really not a thing. So, the doctor needs to take the patient out of the collar, especially. Moving the patient, you need to have plenty of people around. All of your projections, with the exception of the Fuchs, the acanthomeatal line plays a role in positioning of the patient on C-spine. All right, so the textbook says the occlusal plane, and all the way back to Merrill's, also the occlusal plane is what they'll refer to in positioning. But the problem that you run into with the occlusal plane is the bottom of the upper layer of teeth, right? So it's a line that would run from the upper incisors all the way back to the mastoid process. And if the patient is in a collar, that collar comes all the way up to the chin, right? It's supposed to, anyway, if it's put onto the patient properly, and you've probably seen it improperly put on the patient, but the chin should rest in that upper portion of the cup, and the collar is going to come up to about here, right? So the first thing that you're going to have in order to visualize an occlusal plane is you're going to have the patient open their mouth, and their chin is right here. So as they try to open their mouth, their head's not going to be able to move much, but it can still move a little bit. If they've got a potential, fracture in their neck, do you really want them moving their head at all? And the answer is no. Right? So that's problem number one. Number two is that you've got to get those upper incisors, a line going from the upper incisors all the way back to the mastoid process. And if your collar comes up to here, then you're going to have to dig into that collar to feel for the mastoid process, right? So you got a sore neck, and you're on this backboard with your head, with no padding under your head, and you've probably been on that thing for a half an hour or better. You're starting to get a little bit sore. Somebody starts sticking their finger down inside of the collar. What are you going to do? Exactly. You got there before I asked the question. You're going to have a tendency to crank your neck, right? So that becomes a problem as well. Your patient's going to have a tendency to want to pull away from you, and that's going to feel good, right? Because they're getting off of that one sore spot on the back of their head, and then they're going to want to move their head all the way around. So again, do you really want your patient who has a potential neck injury doing that? And the obvious answer is no. So the line that goes from the acanthion out to the EAM pretty close to parallels that occlusal plane. So a much better thing to focus on, and you don't necessarily have to have the patient open their mouth yet. Eventually you're going to get to an open mouth odontoid, but for the APs, the laterals, and everything except for the open mouth odontoid, you can do with the patient's mouth closed, right? So occlusal plane, I'm going to refer to the acanthomeatal line because I find it to be so much better to use for positioning for C-spine. So with that C-spine, that acanthomeatal line is going to play a part in every projection, again, except for the fuchs. On the AP, the acanthomeatal line should be perpendicular to the image receptor, the acanthomeatal line or the occlusal plane perpendicular to the image receptor. And what that's going to do is once we put that angulation on the central ray, it should as closely as possible put the mental point and the occipital bone on top of each other with that angulation so that you can see as much of the upper portion of the C-spine as you can, okay? So you're not going to see C1 and C2 at all, really. And if you've got any kind of tilt or mispositioning of the acanthomeatal line, maybe they're in a collar and they, you know, it's just not perpendicular, you're either going to have the base of the skull or the peak of the chin over the upper portion of C-spine. So you may only see from C3, maybe even, you know, half of C3 down to about T2 is what you should be seeing, right? But if you can put the acanthomeatal line perpendicular to the image receptor, that's going to put those two objects on top of each other as closely as possible. All right, so we'll just run through all the positioning while we're here. The AP, the acanthomeatal line is perpendicular. Lateral is going to be parallel to the floor, essentially, you know, unless the patient, unless you're shooting a cross table lateral, and then it's going to be vertical, right? The purpose for that is you've got the airway, and then right behind the airway you've got the vertebra, right? So if the chin is tucked, then the ramus of the mandible, angle of the mandible could superimpose the spine. Acanthomeatal line, parallel, keeps it off of that. If your chin is extended, then the vertebrae, especially on the posterior side, are going to be all smushed together, right? Acanthomeatal line prevents that, okay? So on your open mouth odontoid, acanthomeatal line perpendicular to the image receptor is going to put now, because we don't have that cephalic central ray angulation, it's going to put the teeth and the base of the skull on top of each other. So that once you open the patient's mouth, those two things are on top of each other, and you can see the odontoid process the best you can. The obliques, sort of for the same reason as the lateral, acanthomeatal line parallel, right? If the patient's upright, parallel to the floor. Some of your textbooks will also have you on your obliques turn the patient's head into a true lateral. You know, I've got my opinion on that, and that is that, you know, that could potentially rotate the upper portion of the C-spine, but that's just my bias, really. Where does rotation of your skull come from? Where does it occur? All the way down the C-spine? You got a specific mechanism at the top of your C-spine, that's C1 and 2. That's the axis and the atlas, right? So that's where your rotation really comes from. I don't like it. And that's why I don't do it. So, you know, I rotate the patient into a 45-degree oblique, and the head is at a 45-degree oblique as well. So, you know, if you're working with somebody who turns the head into a lateral, what that potentially could do is to remove that upper side ramus from the anterior portion of the C-spine. So, is it wrong? No, I just don't like it. All right, so I'm going to do my 45 degrees. So the acanthomeatal line, with the exception of the fuchs, is going to play a part in everything, but if you happen to shoot a fuchs, then you're looking at the mentomeatal line. So try to get your acanthomeatal line perpendicular, parallel, and you'll get your best outcome. Obviously, if the patient's in a collar, that's just not going to happen. So on your APs, what we're going to look at is we're going to look for rotation pretty much in the same way that we look for rotation in a chest x-ray, right? So the sternoclavicular joints and where they are, But we can also look at the spinous process and where it is. So if, let's say, we're going to build us a vertebra here. It's a very blocky vertebra. All right, so we've got spinous process and vertebra, right? So if we have rotation, what's going to happen is the vertebra is going to go one way and the spinous process is going to go the other way, right? So it should be right dead square in the middle. You can't see the superimposition and shadow, but it should be right dead square in the center. Not of the vertebra, and I'll talk about that in a second. Not in the vertebra, but it should be in the middle, right? So if we have rotation towards, let's say this is an LPO, then what you're going to see is the vertebra go in one direction and the spinous process go in the opposite direction, just to determine rotation. You can look at the mandible, you can look at a lot of different things to determine rotation. So with your angulation, where the spinous process should be is not in the vertebra, but it should be in the joint space directly below the vertebra. So picture the spinous process, it comes out of the back and it drops down a little bit, right? With that cephalic central ray angulation, the body will move up a little bit, but the spinous process is not going to move a whole lot. So it's going to be it should be in the center, but it should also be in the joint space of the joint space directly below it, and the disc space directly below it. So if you're looking at the spinous process of C4-5, it should be, or C4, it should be in the disc space of C4-5. Does that make sense? So to determine angulation, the spinous process is what you're going to look at. So if you're over angled, then what you're going to have is misplacement of the spinous process. And at the same time, if you're under angled, you're also going to have it. And where it's going to wind up is inside the body of a vertebra. And we'll take a look at the difference between those two here in a bit. You're also going to evaluate for, the superimposition of mandible over the base of the skull, mental point over the base of the skull. If you see the mandible over the upper portion of the C-spine, just means the chin was tucked. If you see the base of the skull, this big round artifact, then it means the chin was extended. So open disc spaces. So your textbook is going to call for a range of angulations. 15 to 20 degrees cephalic angulation. Really, that's the difference between whether you're shooting an image with the patient laying flat on their back. If they're flat on their back, then gravity's pulling the entire C-spine down, right? But if the patient's upright, if you remember again back to first semester positioning, we talked about primary and secondary curvatures. And the C-spine has a secondary curve. It doesn't really develop until you get upright, right? So once you stand up and this big globe is mashing down on your spine, you develop that lordotic curve. So with the patient laying flat on their back, you relieve that pressure of the head and the spine straightens out. In that case, you need a 15-degree angulation as opposed to 20 degrees with the patient upright. So difference between, with the patient upright or flat. So this is an example. You see that, especially the upper portion of the C-spine, you've got an increase in curvature as opposed to this one's much more straight. Incidentally enough, this also is the appearance that you're going to see if a patient has soft tissue injury, whiplash. They've been in a car wreck and the neck is stiff. It'll take that lordotic curvature out of the C-spine, and sometimes it'll be bad enough that it'll put a kyphotic curvature in the C-spine. Anybody ever seen that? The neck is bending the wrong way. That's gotta hurt. You wake up with a stiff neck. I don't think your neck is bending the wrong way. It's gotta hurt. So anyway, so AP positioning, we're not gonna hammer that anymore. Okay, so over angled versus under angled. So what we've got here, you see the spinous process is in the center. That's what that teardrop shaped thing is. On each level is spinous process, and it's in the intervertebral disc space. You see that? Okay, well over here it's in the body. All right, so I wish these were of similar densities, right? but they're not. So the body is here, spinous process is there. Two things about overangulation. One is, you see how the body is, you know, it's not really square. You know, it's more rectangle and kind of a softer appearance than what it is over here. It's just completely blocky, except for up on the corners, you got these little horn-looking things, and that's what we call the uncinate processes. Uncinate processes elongate when you over-angle, and the vertebra looks much more blocky. This guy right here looks like, you know, some kind of anime character or something, I don't know. But it's much more blocky appearance, and it's got, you know, these elongated looking horns, as opposed to under-angled. You're also going to have the spinous process inside of the vertebra, see here? And that is decidedly not blocky, right? That's just, you know, the whole thing looks like it's squished. So again, back up here, we've got spinous process in the body. The body is big, and you've got elongated uncinate processes. Here, we do not have the elongated processes. The entire vertebra looks like it's smished, and we've still got the appearance of the spinous process inside of the body. Okay? So it's all about spinous process. All right, so a couple of different things mispositioning wise. Remember, you should be getting down to about T2, so you should be able to visualize the clavicles. And if you've got one clavicle coming across the vertebrae, you've got some rotation, so this patient will be into an LPO. I really think that this was a botched oblique rather than a botched AP, because surely you would not look at the positioning of this person and think, yep, that looks like a good AP, right? So I think this was a botched oblique, but it kind of makes the point. Is probably under-rotated oblique. And this is just, you know, if the patient's in the collar wrong, or, you know, just on the table with their head tilted, you know, you're going to have some dissimilarity between the disc spaces, and it's just not, I don't think it's repeatable. This is definitely repeatable. I don't necessarily think I would repeat this, but it's just kind of sloppy work. As opposed to these two are both repeats. We've got, you see this big round thing here? That's the base of the skull, as opposed to the square thing here is the jaw. So what we've got here is the patient's chin is too far back, as opposed to this, the chin is tucked, right? So a canthomeniatal line, if we're putting that perpendicular to the image receptor, would fix both of those. I think we're probably under-angled on this one, possibly over-angled on that one as well. So we've got a couple of positioning errors. Let me get back to this. So sometimes too, you'll have a patient who is kyphotic or just barrel-chested, and you're trying to shoot a good AP with the patient on the table. And you try to get the patient to tuck their chin down far enough to put the AML perpendicular to the table, and they just can't get there. And that's because of that big barrel chest or the kyphosis in the back. You know what emesis spacing is, right? That little kidney bean shape, sometimes green little thing with the, you know, little sides that go in at a little bit of an angle. That if you were to get sick, you would not want that thing to throw up in, right? Because it's too shallow, it's angled, and it's just not big enough to hold the contents of somebody's stomach. But the one thing it's good for is this. It's plastic, so it's radiolucent. Only thing I've ever found good about that thing is that you can turn it upside down, put it on the table, put a towel or a wash rag over the top of it to provide a little bit of padding, and put the patient's head on. And most of the time, it will bring the patient up to where their acanthomeatal line is pretty close to being perpendicular. Okay, so you might have a little bit of increase in OID, so a little bit of magnification, loss of sharpness of recorded detail, but it's not going to be as ugly as that, right? So just, you know, hopefully. All right, so the open mouth odontoid. I've worked with techs, new techs in a hospital. I'm familiar with protocol, and you know, they get an order for like two view C-spine. There's only ever one reason should tube view only tube view C-spine, and that is flexion and extension. Every tube view C-spine, because, especially in a trauma situation, because you can't get C1 and C2 on the AP, this completes the AP. Okay, the open mouth odontoid completes the AP. So there's never, aside from flexion and extension, truly a tube view C-spine. So if you go to work somewhere aside from your clinical facility and you get an order for a tube view C-spine that does not say flexion and extension, it's a 3-view C-spine. Minimal, at least a 3-view C-spine. AP, lateral, open mouth odontoid. Never seen anything aside from that. So hopefully your protocol, your computer protocol calls for 3-view, but if you get 2-view, it's a 3-view. Okay, so this completes the AP. Canthal-meatal line perpendicular to the image receptor. Generally, when I would position for one of these, preferably, the doctors come down by this point and remove the collar, or at least taking the front of the collar off so that you can have the patient open their mouth wide enough to actually get this. If you tell the patient, open your mouth as wide as you can, what are they going to do?
Lean the head back.
They're going to lean their head back. They're going to open their mouth real wide, and they're going to mess up your positioning of the AML. So I'd always put my hand on the patient's forehead and say, okay, I want you to drop your chin and open your mouth as wide as you can. Okay, so that's a little deeper instruction, and the patient can kind of grasp, I don't want you to move your head, right? So they open their mouth as wide as they can. And what you can do is you can take your x-ray tube, align it to the bucky, right? And then move the patient until the crosshairs are right on their acanthion. Open your collimators up so that you can see where that line runs into, this line that would run across the patient's face goes into the EAM. And then move the patient, just to align the AML perpendicular to the image receptor, and then move the patient, move the tabletop until it's going through the open mouth. Have the patient open their mouth at that point. Obviously, collimate down also, right? Very small area for collimation. And just shoot through the open mouth. So it completes the AP. Use your AML occlusal plane. The occlusal plane is teeth and mastoids. And what we're going to want to visualize, if at all possible, if the patient, if you've positioned properly and the patient's anatomy is cooperative, then you should see the entire dens and you should be able to evaluate C1 and C2. Sometimes patient's anatomy isn't cooperative and you won't get the tip of the odontoid process. But you still need to get a good open mouth odontoid to see all of the other stuff. We're going to take a look at a couple of fractures here in a bit, and we'll talk about why it is that the good open mouth odontoid is absolutely necessary, especially to see the bottom of the dens and the lateral masses C1 and 2. Okay. A lot of people want to fall back to a default position. I'll just, I'll try to shoot open mouth odontoid, but I'll get it on the Fuchs. Fuchs just doesn't catch the most important anatomy on a C1 and C2. All right, so position like that, what we're looking at, the lateral masses, really all that means is the alignment between C1, the lateral portions of C1, lateral portions of C2. So they should be about the same size, right? So we want to be able to visualize that, see where the lateral masses of C1 are in relationship to C2. We want to be able to see down at the bottom of the dens. If you don't get the very tip of the dens, I'm not going to say that's not important, but I am going to say that it's less important than seeing the lower third, lower half even, okay? So we're going to look at rotation by looking at the teeth and where they are in relationship to the odontoid process. So the back teeth, the spinous process, the distance between the dens and the lateral masses, and any kind of rotation, if your ER doc or your radiologist is in a hurry, might look like a Jefferson fracture. A Jefferson fracture may look like rotation, and that second is a more significant issue, okay? So what I mean by that is if you're rotated, then what you're gonna see is the teeth go in one direction compared to everything else, right? Kind of the same situation here is if we were to rotate towards the left-hand side, the teeth are gonna go towards the left-hand side compared to the dens C1 and C2, okay? So what that's gonna give us, we're still not gonna have any significant difference between the lateral masses, but it's kind of gonna look like it because of the position of the odontoid process within that entire structure. It's gonna look a little bit like it. So why don't we give the Fuchs a rest for a second and look at what the issue there is, okay? So what we've got in potential fractures of the odontoid or C1 and C2, Jefferson fracture is what we refer to as an axial loading fracture. It occurs when somebody falls from a height and they land on top of their head. The weight of the body coming down onto C1 and C2, specifically C1, is potentially going to snap the ring of C1. I remember when we talked about mandibles and the pelvis, if you break a bone that's sharply curved, it's not just going to break in one place, it's going to, at least two places. And the odontoid, not the odontoid, but C1 is no different. So if the patient falls on their head or something heavy falls on top of their head, then all that energy impacting C1 could potentially break it. And once it breaks, even if it just minimally displaces, what you're going to see is dissimilarity between the lateral masses of C1 and C2. C1 is going to be projected out past the lateral masses of C2, indication of a Jefferson fracture. Now visualize your Fuchs. What do you see on Fuchs? I didn't get a picture of Fuchs to put up here. What do you see on Fuchs? You see the dens inside the foramen magnum. You gonna be able to see that? No, not at all, not at all. I think though that I did put, okay, here we go. So again, visualize your Fuchs. What do you see on Fuchs? Circle, foramen magnum, and just the dens, right? That part. What do you see there? If you got a fracture with displacement, you think it's important to be able to catch that? Now you got a bobblehead, right? And you got the entire odontoid process snapped off at the base, okay? So what I'm trying to get to here is don't do that, right? We gotta have a good open mouth odontoid. Even if, I mean, this is not perfect, right? That's the base of the skull going across it. You don't see the teeth anywhere. So this is poor positioning, but can you see what the problem is with this patient? The answer is yeah, you can. So get some measure of a good open mouth odontoid so that you can see, you know, those lateral masses and the base of the odontoid, preferably at least the lower half of the odontoid. That's where most of your fracture is going to take place. Might you have a fracture of the tip? Yeah, you might, but it's not going to be as dangerous as something like that. Okay, good open mouth odontoid. Fuchs doesn't give you that. So your one saving grace is that you can also diagnose these fractures on lateral. So what we've got here, you see, we'll count up from the bottom, roughly count what we got here, maybe 6, 5, 4, 3, 2, no, 7, 5, 4, 3, 2, 1, nope, 7, 5, 4, 3, 2, and then 1, right? But look how nice and aligned these are, and then that one just kind of falls off backwards, right? So the benefit of the lateral is you can see most of these fractures on the lateral. So if you can't get, I mean, the lateral is better for diagnosis of a potential C1 fracture than, or C2 fracture, dens fracture, than what the Fuchs is. Okay, so that's It's protocol in some hospitals, so I gotta not say that it's useless. But come on. Hey, come on. You know, you run with dogs, you get fleas, you know, and if it acts useless and it seems useless, it's pretty close to useless. So it's not useless, though. But it hangs out with the useless all weekend long. All right, so good open mouth odontoid. And then if you don't get the tip, yeah, include a fuchs, but make sure you get a good open mouth odontoid, as good as you can get. Okay? So stepping off of my soapbox there. Fuchs. I'm just going to leave it at that. Okay, so lateral, we already talked about the AML distance. We want to get 72 inches if at all possible. Can't get 72 inches in a trauma situation, that's okay. Just get what you can. What you might do in a trauma situation if you can't get 72 inches, and the purpose for the 72 inches is to use more of the center of the central ray. Thinking about the divergence of your central ray, at 72 inches you got two things. One is that you've got to increase no ID, right? You got to increase no ID. So you need to increase SID to decrease magnification. That's number one. Number two, though, is that at 40 inches, your divergence of the central ray is much greater than what it is at 72 inches. You use more of the center of the central ray at 72 inches than what you do at 40 inches, right? And this is poor radiation protection, but if you're in a true trauma situation, you might get more of the C-spine, lower portion of the C-spine, if you intentionally misposition. This is a hint for y'all. This is not in any textbook, and again, it's poor radiation protection, but it's potentially good patient care all at the same time. Is that if you are shooting at 40 inches because of the great divergence of the central ray, what you're going to do if you center at C4 is you're going to project the lower portion of the C-spine into that downside shoulder. Does that make sense? Because the middle of the central ray is here. This portion of the central ray is going down, right? So what you might consider doing if you really kind of think the patient may have a neck issue is to center your central ray a little bit lower. Pull the patient's shoulders down, try to get them out of the way, but center your central ray a little bit lower so that the most perpendicular portion of your central ray is around C7, T1. So you're not projecting downward and projecting the C-spine into the downside shoulder. Does that kind of make sense? Mm-hmm. So that the center of your central ray, most perpendicular portion of the central ray is on that lower portion of the C-spine. That's going to project everything else up and away from the shoulder. But it's important to get a good pull on the shoulder. Swimmers, I'm not saying swimmers is useless. It's less useless than a fuchs. But it's an ugly x-ray, and the only thing it really shows you is alignment, right? And we're going to take a look at that here in just a second and possibly introduce another little tip that you might want to incorporate. Also, don't see it in the textbook, okay? So you're centering top of the collimated field. Most of your radiologists want you to get on your lateral all the way up to the sella turcica. And the reason for that is because you can have a rupture of the ligament that holds C1 into the anterior arch, the dens into the anterior arch of C1, okay? Technically, that's a broken neck, even though you have no broken bones at all. If you rupture that ligament, you clinically have a broken neck. And what's gonna happen is that the line that runs down the backside of the sella turcica is what we call the clivus. Remember the clivus, right? The clivus should point to the dens. All right, it should point right to the tip of the dens. So if you've got misalignment of those two things, and essentially what you've got is the dens too far posterior, it's not in the right place. Okay, so it's a clinical indication the patient has a broken neck. You're going to go to CT for sure now. But if you center such that you only get the top of C1, C2, and you don't see the sella turcica, you can't evaluate that clivus. You very well could miss that. Okay, so top of the collimated field, top of the ear, for that reason. And if you have done everything that you can do to get down to C7, T1 and you just can't do it, now you've got to do a swimmer's. Now you're up to a 4-view for a 2-view C-spine, right? So you get an order for a 2-view C-spine, it's AP, lateral, open mouth odontoid, possibly a swimmer's, right? So what we're gonna see, we already talked about that, positioning errors, it's either gonna look a little too AP or, you know, it's gonna look oblique, really, not too AP, but it's gonna look oblique. But soft tissue structures of interest. So what we've got, you know, we call it prevertebral fat pad, but really what it is soft tissue between the vertebra and the airway, right? All the images that I put into this, I think were probably a day or two after the trauma that caused the injury. My personal experience is every time that I've had a patient had a true C-spine injury, not whiplash, but true C-spine injury, the swelling was such that that prevertebral fat pad, instead of being maybe a half an inch, was, you know, 2 inches. It was massive. Hangman's fractures, things like that, you're going to get a tremendous amount of swelling. So you have to be able to visualize that you know, prevertebral fat pad. And really what you're looking for is displacement of the airway. So we're going to look at all these different types of fractures. We'll kind of do a little bit of a, you know, bump and go on the obliques, and you know, because you just don't see a whole lot of them anymore. And we'll talk about the swimmers and look at some, you know, helpful hints on that. So types of fractures, we've got subluxation, pseudo-subluxation. Those usually come with other types of fractures, named fractures in the C-spine. Teardrop fracture is a very unstable fracture for reasons I'll show you here in a bit. Jefferson fracture we already took a look at. A lock facet is kind of like, maybe your lock facet didn't come with any kind of fracture, but you know, your facet joints and your zygapophyseal joints are the same thing. So if the patient gets in some sort of accident, especially a rollover accident, where they don't necessarily completely sublux, but one side does, then you know your zygapophyseal joint should look like that, or your facet joint should look like that, right? So that you've got a joint space, you got superior articular process and inferior articular process. And if your superior goes anterior to your inferior, you've got a unilateral lock facet. You can see it in a lot of cases on the lateral. I've got an image up here where you can see it on the lateral. But if it's down C7, C6, 7, a patient with broad shoulders, you're going to have a hard time visualizing that. So I'll talk about in context of some place that you might actually see some obliques done. But anyway, that's lock facet. Hangman's fracture, we'll talk about that. And then we already talked about whiplash. So lateral here, obliques, you know, obliques, what we're looking on lateral, yeah, let me get to that. Zygapophyseal joints, right? So lateral on C-spines, zygapophyseal joints, and then our obliques, we're going to be looking at the intervertebral foramina, that's that hole right there. And what we should see is not just the open hole, but you can kind of see where what you're kind of looking down on here is the lamina, kind of looking straight down onto it. And this one kind of shows it a little bit better. They kind of look like shingles on a house, so that the shingles on the house, what you've got is the shingle above should the bottom of the shingle above should overlap the top of the shingle below it, so that if it rains, you know, the rain runs off your roof, right? If they were the other way around, then you're going to get water in your house, right? So the two things that we're going to look at is that, and you're also going to look for the open intervertebral foramina for the obliques. Our lock facet will look like you put a layer of shingles in the wrong place, right? It looks like you started off well, started working from the bottom up, and then at some point you decided to go from top down, and you're overlapping your shingles, essentially overlapping your shingles in the wrong direction. So what we'll have is, instead of this overlapping that. This will be anterior to that so that water could run into your house, so to speak, right? So this is what I want you to know on your obliques is you might wind up in a hospital, those two things, but also you might wind up in a hospital, again, where they're hesitant to send the patient straight to CT for just any old thing. So if the patient potentially has some sort of injury, especially on the lower portion of the T-spine, that a locked facet might not show up on your lateral, they may ask you to shoot obliques. But the problem is the patient's on a backboard. Patient's on a backboard, how are you going to do obliques? that's one possible. That's one possible, just muscle them up, right? But the problem is you start rolling them up like that, and well, they're going to have a tendency, you got to get to 45 degrees. Bump, right? Now they're in the floor. Not a good look. So how could you accomplish what do you have to have for a good oblique? Two things. Angle it, right. So you got a double tube angle. So you're going to oblique the patient 45 degrees and angle your central ray 15 to 20 degrees cephalic. It's going to be ugly. So you angle the central ray 45 degrees from lateral to medial. And what that's going to do is it's going to take your vertebra and it's going to kind of stretch it out. So it's going to be ugly. Can't get around that. It's going to be ugly. It's going to be distorted, but you should be able to accomplish the same thing and get the same look out of it. Okay. So I have worked in a hospital where that was protocol. If you could not, swimmers wasn't a thing. I said, I want a swimmers. Just don't send me that. If you can't get down to C17-1, trauma obliques is what you had to do. Okay. So you got that great big image receptor. So you got a little more room to play. What we used was 10 by 12 films. Date myself. 10 by 12 films, and we had to put the edge of the film right under the patient's head and angle, otherwise you were going to miss it. You were going to project it off the image receptor. Ugly x-rays. You've got virtual grids now to help clean up the scatter. You can't use a grid for that because it's double tube angle. But you got virtual grid to help clean up the scatter and make it a better looking image than what it used to be. All right, so swimmers, we're going to take a look at. My recommendation on swimmers is shoot on exhalation. I've worked with techs who used a breathing technique swimmers. Never had any luck with that. I'm not saying that they're wrong in doing so. If they have good outcomes with breathing technique swimmers, more power to them. I'm just saying I never could pull it off well. So exhalation, the purpose for exhalation is take that those lungs, and collapse the lung as much as possible in the upper portion, of the thoracic cavity to increase the density and make it more uniform. Okay, so exhalation, the position of your shoulders. I've had students, it seems like every year would have a tendency to flip which arm goes up and which one goes down. So always the side closest to the image receptor, angle the central ray caudally. If you can't accomplish that, maybe you work in a hospital where you can only, with a specific patient, maybe you can only shoot from one side of the table. And so let's say this shoulder is injured, you can't get it up. You have to elevate the side furthest from the image receptor. Okay, the purpose for that angulation and elevating that shoulder is to separate the shoulders vertically, right? So you elevate one, it goes that way, you angle the central ray, and the other one goes in the opposite direction, right? So if, though, what you do is you elevate the upside shoulder and you still angle caudally, what you're doing is you're taking that one, putting it up, and then you're projecting it straight back down on top of the other one. So if you find yourself in a situation where you have to elevate the side that's furthest from the image receptor, angle cephalic instead of caudal, okay? But preferably elevate the side closest to the image receptor, caudal angulation 5 degrees. And this is just something I had success with, is possibly rotating the patient a little bit. Okay, so what you do with the angulation and elevation of shoulders, you separate this way. But if your vertebrae are still running straight up and down through that region, you're still going to have significant superimposition, right? So what I would do with my swimmers, and we'll take a look at an image that is in the textbook as being mispositioned, but I think that you can see the vertebra a whole lot better. is oblique the patient just a little bit. And I mean just a little bit. And it's only about a 5-degree oblique. And with a 5-degree oblique, and I've got my hands real close together here, but at shoulders width apart, 5 degrees is pretty significant because this one goes 5 degrees that way, this one goes 5 degrees that way. You got 10 degrees of separation, right? So what that does is it desuperimposes the shoulders not only vertically, but also horizontally. Now, let's take a look at you know, what I'm talking about here. All right, so this is good swimmers. Also, most of the radiologists I've worked with have, and this is poor radiation protection as well, most of the radiologists I've worked with have said that they wanted your swimmers to be shot so that they could count from C1 or at least C2, okay? Which means that if you're centered to go through C7T1, your central ray is centered to go through C7T1, which you should, your collimation is going to be open such that you're going to include from about C2, C1, C2, down to about T4, right? So you got a massive area of exposure there. But the reason that they want that is because, look at this thing. You know, I mean, it's a mess, right? And there are telltale indicators of where you are, okay? So the clavicle should be going across. This is downside clavicle, that's the upside clavicle, side clavicle, and you can tell the difference between the two because of the magnification. The downside clavicle should be going across C7, okay? So telltale indicators, that's where you are, but the better indicator is to be able to visualize the vertebral prominence, right? So you've got, down at the bottom of the C-spine, your spinous processes get much, much larger, right? So that's a good indication of C7, and better than that, right? What if you got a patient who's got one of those long necks and low shoulders? You know, is that going to be accurate? Is it always going to be going across C7? The answer is I don't know. So a lot of your docs say I want to see from C1, C2 down so that I can count. C2 has a specific enough look that, you know, you can count down from C2. So elevate one shoulder, depress the other one. So we got one up, we got one down that we can't really see. So look at this. So we've got, you know, 2 here with slight rotation. And look back here, you can see the spinous process is much better. You can see the vertebra a whole lot better. Again, the textbook calls this mispositioning. I call this better, right? So you do what you want to do, but you know, I think this is a much better outcome, and you can see the vertebra so much better. If you were to try to make a diagnosis of, you know, T1, you know, C7, T1, C7 you can see pretty well, T1 is gone, right? But if that's C7 here, then that's T1, you can see pretty well. So, just a suggestion. I'm not saying you gotta, but just a suggestion. So, let's see. Other ones, teardrop fracture. Teardrop fracture is a nasty fracture, and it's not just because of the fracture itself, but it's because of what happens with the fracture. So the fracture is just a small fracture off of the inferior anterior portion of the C-spine. But the real issue is that you remember talking about the Masseneau fracture in the tib fib, or you take that syndesmosis and you destroy the syndesmosis. Kind of the same thing here. What you've got is not just the fracture here, but all soft tissue connection is obliterated, extremely unstable. Probably more so than a hangman's fracture. It's just a nasty, nasty fracture. So, you know, if you have a patient and you see a little chip off the front like that and it looks pretty insignificant, don't count it as insignificant. Bring it to somebody else's attention. You can see on this one, I wish we could see the spinous process of this one down here a little bit better, but you see how they're pretty evenly spaced, and this one just goes boom, right? The rest of them are kind of normal, and then this one is just so wide apart that you can't see the spinous process. So teardrop fracture, extremely unstable fracture. Hangman's fracture, is what we've got here. So Hangman's fracture is a fracture dislocation at C2-3, and it also occurs in rollover accidents in a lot of cases. Possibly T-bone. Probably the worst one I ever saw was somebody ran up under a semi, and his hyperflexion, his man and wife, and he was perfectly fine, but she got hyperflexed and it broke her C-spine. The hardest part about that particular case was we saw her in the trauma room, right? And then we saw her husband, who was oblivious, had no idea that she, in a blink of an eye, was snatched into the body of a 90-year-old person. No idea. He was joking, having the best time, and so we held it together, got him taken care of, sent him back to his room, and not 5 minutes later we got orders for more stuff. It's like, because we know what's coming. And we go back down there, and the guy's he's beside himself. He's just destroyed. His wife's never gonna walk again because they told him. The first time he didn't know, the second time he did. So anyway, Hangman's fracture, just nasty as well. But sometimes Hangman's fracture does not wind up with as serious outcomes as what your teardrop fractures do. Sometimes you'll have a patient with a Hangman's fracture and they've got no neurological deficit. Either way, they're probably going to get a halo, and that's what you're seeing here. Halo is this thing. If you've not seen one, it looks like a torture device. So you got this thing going around the patient's head with pins going into their head, and then they're wearing this harness on their shoulders, these connecting rods. And the purpose for this external fixator is all it is, and the purpose for that is to stabilize the head while the patient heals. That could also be traction, though. Anybody ever seen anybody in cervical traction? That's got to be miserable. If you've not, kind of the same situation. They'll put something on the patient's head, sometimes with pins in it, sometimes just with weight on it, and they'll hang weights off of the head of the bed just to try to pull traction on the patient. Yeah, pull traction on the patient's head. So hopefully, like in a situation like this, that may be what that is, to pull traction on the patient's head so they can reduce that dislocation. Ugly. And they may be in that situation for several days. And then a clay shoveler's fracture is, it's a kind of like an avulsion, and it's, of all these things we've talked about, it's most stable. If you've ever dug a hole in East Texas, you know that digging through clay is murder, right? Even if you get your shovel through the clay, you pick it up and you go to chunk it, and what happens to the clay? It tries to drag you with a shovel, right? And it's a stress injury is what it is, and it results in a fracture of the spinous process C7. Clay shoveler's fracture. Painful, I'm sure, but it's not anywhere close to life-threatening. And finally, we got one more thing. It's called pseudosubluxation, and this is specific to kids. So pseudosubluxation is a normal variant, and it occurs because kids' heads are abnormally large, right? I've got an 8-month-old grandson and a 3-year-old grandson, and I'm not sure either one of them can touch your fingers on top of their head. They just got this massive head, and so they have to have something to support it. So C1 and C2, in a lot of cases, are overdeveloped. And I think there's actually a measurement that is the diagnosis or a diagnosis of subluxation versus pseudosubluxation. So if we appear to have subluxation of C2 on C3, kind of like Hangman's fracture, and it's 2 millimeters or less, then that's pseudosubluxation. Anything more than that is suspicious for subluxation. So what they're going to look for is posterior alignment of the body, posterior alignment of the vertebra, and not so much looking at the anterior alignment of C1, C2, C3. Okay, so as the baby develops, as the kid develops, eventually they're going to outgrow that, and the rest of the vertebrae are going to catch up to it. But when they're that young, there's a very good likelihood that they've got pseudosubluxation. So what we may be called to do sometimes is to rule that out and look, for that posterior alignment, is the ER doc will clear the kid. So we've done laterals, AP, he's done his, his clinical assessment, whatnot. They might ask us to get the patient up and do flexion extension views. Okay, now you're truly into a 2-view. Certainly, what you would want to do is have the patient do their flexion extension and not try to talk them into anything more than what they could do. But with the flexion extension, what you should see is a little bit more movement or dissimilarity on the posterior alignment that would indicate true subluxation as opposed to pseudosubluxation. Okay. Never seen a situation where I got a kid up, did flex X views, that it was not pseudosubluxation. So, it's not like you're going to be called on to do that with every kid that comes to the ER. Just if, it has that appearance and they're clinically sound, you might be asked to. Oh, I said one more thing, but this is the one more thing. Lock facet. So you see the nice appearance to the facets here. Nice dark line. Don't know what happened there. That would be the classical appearance of lock facet. So this one being at 3.4, C3.4 is, obviously diagnosable on just a lateral. But if you were down here, C7T1, you're gonna have a hard time getting that. So that's where your trauma obliques would come into play, is if you were into a lower C-spine potential for unilateral lock facet. If both of them jump, now you're truly in a subluxation, even if there is no fracture present clinically as for the neck. Okay? Any questions? I know it's been a long day for y'all, so I tried to get through C-spine as quickly as I could without sacrificing too much. But I'll put these into, I don't know that I won't add some more T-spine and L-spine, but I'll put these into Canvas. So